There are some relative contraindications to the percutaneous interventions, which include patient factors and anatomical factors. Patient factors like GI bleeding that prevent 4 to 5 hours of anticoagulation during or following the stent, inability to take dual antiplatelet therapy, conditions prone to hemorrhage, intracranial hemorrhage, recent surgery or bleeding diathesis. Anatomical factors are small vessels less than 2.5 mm, vessels with poor distal runoff or severe diffuse disease, vessels supplying poorly functional or non-functional myocardium, and heavily calcified vessels. Complex stenting. Stenting for patients with complex anatomy should be carefully considered. Any of the following characteristics are considered at higher risk for complications: long lesions requiring more than one stent per lesion, small coronary artery reference vessel diameters below 2.5 mm, significant thrombus at the lesion site, lesions in saphenous vein grafts, the left main coronary artery, ostial locations or bifurcation lesions, restenotic lesions. Diffuse disease or poor outflow distal to the identified lesion, very tortuous vessels in the region of the obstruction or proximal to the lesion, unprotected left main stenosis, complex coronary artery disease with significant impairment of LV function. Over the past decade, the indications for stenting have expanded, demonstrating a favorable outcome in nearly every anatomical subset studied. These subsets include native coronaries that are 3 mm or less in diameter, stenotic vein grafts, restenotic lesions after non-stent interventions, chronic total occlusion, acute MI, bifurcation lesions, ostial lesions, unprotected left main stenting, multivessel stenting. Potentially favorable but as yet unproven situations for stenting include small vessels, long lesions, and diffuse disease. Delivery technique. The delivery of a stent to the lesion is usually performed after initial balloon angioplasty. A preliminary balloon dilatation provides the operator with the information on the difficulty of negotiating the artery and crossing the lesion, as well as helping to select correct stent size. After the stenosis is opened, the increased blood flow produces flow mediated vasodilatation. The vessel diameter is often larger than when seen before dilatation. Stenting without predilation is called direct stenting. Although this method saves a small amount of time, the advantage is minimal. Delivery technique. The delivery of a stent to the lesion is usually performed after initial balloon angioplasty. A preliminary balloon dilatation provides the operator with the information on the difficulty of negotiating the artery and crossing the lesion, as well as helping to select correct stent size. After the stenosis is opened, the increased blood flow produces flow mediated vasodilatation. The vessel diameter is often larger than when seen before dilatation. Stenting without predilation is called direct stenting. Although this method saves a small amount of time, the advantage is minimal. Stent implantation technique differs from balloon angioplasty technique in two respects. First, selecting the correct stent diameter and length is more critical than balloon sizing because a stent becomes a permanent implant and undersized stents are associated with poor long-term results. And second, stent delivery to stenosis can be more difficult than advancing a balloon catheter because of vessel calcification, tortuosity, angulation, and lesion length. These conditions are not generally problems for balloon catheters, but they can be significant problems for stents and must be considered beforehand. Stent delivery can be performed equally well from the femoral or radial approach with six French sheaths and guide catheters. If double balloons or stents are anticipated for bifurcation lesions or for rotablator, seven French or eight French systems should be used. Before stent implantation, predilation with a balloon that is slightly undersized relative to the reference vessel diameter is a safe strategy that gives the operator useful information such as the pressure needed to expand the lesion. Using a slightly undersized balloon also leaves an indication of the lesion so that the stent can be optimally positioned. Predilation also allows for the vessel to be fully repressurized with restored flow, which often produces vasodilation. It is not uncommon to find a vessel enlarged after balloon dilation. This enlargement results in the operator selecting a larger stent than would have been chosen initially. Alternatively, an operator may choose to go directly to stenting without balloon predilation. Although this method is usually successful, stents cannot always be delivered to the lesion site because of tortuosity or calcifications. In these cases, exchange for a balloon catheter, predilation, and or exchange for a stiff guide wire may be needed. It is disconcerting to the operator to place a stent directly in a lesion only to find that the stent cannot be fully expanded because of heavy calcification. Undersized stents may be selected because of unappreciated flow mediated vasodilation. Stent implantation and expansion. After having positioned the stent, the operator should recheck the position relative to the side branches and landmarks of the target lesion. It is important to remember that the stent is a permanent implant and time should be taken to place it correctly, thus avoiding additional and unnecessary stents. It is also important that the stent covers the entire length of the dissection or lesion without leaving any inflow and outflow obstruction. Stent expansion should be performed under fluoroscopy to judge whether it is fully expanded and to ensure that its diameter matches the proximal and distal reference coronary artery diameters. Optimal implantation requires that the stent struts be in full contact with, also known as apposition, to the arterial wall. If the stent is not symmetrically expanded, a larger balloon up to 4 mm or a high inflation pressure more than 14 atmosphere may be used. Ideally, the final stent diameter should match that of the referenced vessel. All efforts should be taken to ensure that the stent is not underdilated. IVUS imaging is the only method of guaranteeing this. IOS optimization based on the reference lumen. Successful stent expansion is achieved when there is no significant difference between the lumen diameters of the stent and the reference site, particularly the distal reference. And secondly, there is complete apposition of the stent to the vessel wall. For small vessels, the IOS criterion of achieving a final stent lumen cross-sectional area more than distal reference lumen cross-sectional area is strongly recommended. In larger, more than 2.5 mm vessels, a final stent lumen cross-sectional area more than the distal reference cross-sectional area is acceptable with optimal stent apposition. This is accepted because the reference site in large vessels commonly have less disease in the reference segment than do the small vessels. This also makes a final stent lumen larger than the distal cross-sectional area more difficult to achieve in large vessels than in small vessels. Typically, a final stent lumen cross-sectional area of 80% of the distal reference vessel is accepted. IOS optimization based on reference vessel area. Using criteria based only on IOS vessel area has the inherent flaw of not incorporating stent expansion relative to the reference lumen cross-sectional area. The use of a criterion of 50% of the average vessel area would leave a significant number of patients with a stent that was underexpanded compared with the distal lumen. The use of a criterion of 60% of the average would position the final stent lumen between the cross-sectional areas of the proximal and distal reference lumens. The use of reference vessel criteria has the disadvantage of requiring multiple additional measurements in contrast to using the reference lumen criterion, which requires only a few. The figure shows the stent struts, media, plaque, and lumen and IOS catheter. There is a narrow space between IOS catheter and the lumen surface. At stent site versus distal reference. And in the lower diagram, the stent site and distal reference are compared, and there is a wider space between the stent struts and the media. So IOS assessment of stent deployment at the top shows asymmetric deployment in a small vessel, and at the bottom it shows asymmetric deployment, which can be improved in the large vessel. The starred area is distance to wall. IOS optimization based on final balloon size. A simplified guideline for assessing final stent lumen uses the balloon chosen for final stent optimization. The interventionalist usually selects appropriate size balloon based on visual estimation of the diameter of the reference vessel. The minimum cross-sectional area of the stent lumen should be more than 70% of the calculated cross-sectional area of the balloon selected based on the angiogram. This simplified criterion provides a safety buffer in small vessels where the risk of stent thrombosis is higher and is less strict for larger vessels where the risk of stent thrombosis is less. Stent expansion strategies. There are two methods of optimizing stent expansion and improving the cross-sectional area of the stent lumen. First is high pressure and second is a larger diameter balloon. When an oversized balloon is used, there is increased likelihood of coronary vessel rupture or dissection. Using high pressure with a balloon that is appropriately sized to the vessel allows stent expansion to occur within the natural confines of the vessels. To avoid complications, the ratio of balloon to the angiographic reference vessel should be approximately 1.0. If a balloon to vessel ratio is more than 1.0, a short non-compliant balloon with medium pressure 12 to 16 atmosphere is preferable. When a balloon larger than the angiographic vessel diameter is used for final stent optimization, it should never be larger than the distal IVUS minimum vessel diameter measured media to media. When there is a large differential between the size of the proximal and distal vessels, as may occur in the left anterior descending artery before and after the second diagonal, careful balloon selection is important. In general, using slightly lower pressure in the distal part of the stent segment and a higher pressure for the proximal portion of the stent is all that is necessary. Care should be taken not to dilate beyond the distal edge of the stent with an oversized balloon. Occasionally, if there is significant vessel tapering, dilation with two balloons of different diameters should be considered. Non-compliant balloons are preferable to compliant balloons for final dilations for several reasons. NC balloons will expand and dilate uniformly even in focal areas of resistant lesions, and they are more likely to maintain a uniform diameter even at high pressures. Thus, non-compliant NC balloons allow for optimal stent expansion without overexpansion of the balloon in adjacent unstented segments, which contributes to dissection. In addition, experience with IVUS has shown that 25% of stents have improved stent expansion with an increase in pressure from 15 to 18 atmospheres or more. Asymmetrical stent expansion. Stent expansion should be symmetrical in soft blocks. Very hard blocks, fibrotic or calcified, seen in approximately 20 to 30% of the lesions, are not easily compressed by the balloon or stent, resulting in asymmetric stent expansion into the normal arc of the vessel. In lesions with significant arc, that is to 70 degrees of dense or hard fibrocalcific disease, asymmetrical stent expansion occurs with a minimum to maximum lumen diameter ratio symmetry index of less than 0.7. In such lesions, further inflation leads to local overstretching in the less diseased arc of the vessel. The symmetry index can worsen after further dilation, especially if an oversized balloon is used. Large balloon asymmetrical expansion with focal overstretching, showing a calcified block and acoustic shadow. Balloon size step down, one size down, and very high pressure inflation. Stent symmetry is improved and stent cross-sectional area is not improved. Balloon inflation strategy based on IVUS after stent placement. In the first diagram is asymmetrical stent expansion may require larger balloon, and in the second B diagram stent symmetry is improved but cross sectional area is not increased. Use smaller balloon at very high pressures. Using a balloon that is 0.25 to 0.5 mm smaller than the size of the vessel and very high pressure of above 18 atmosphere may improve the symmetry index but will not necessarily increase the cross-sectional area of the lumen of the stent site. Asymmetrical overexpansion is associated with the risk of vessel rupture. The risk is highest if a larger balloon is used. If the stent lumen cross-sectional area is acceptable relative to the distal lumen cross-sectional area and the stent is well apposed, efforts to make stent symmetry perfect should be avoided. Incomplete stent expansion. Adequate stent expansion is dependent on the plaque burden. Optimal stent expansion in lesions with 50 to 70% diameter stenosis or lesions with a spiral dissection can be easily accomplished because there is no much atheroma. In lesions with more than 90% stenosis, optimal stenting is more difficult to achieve and is associated with a higher percentage of asymmetrical stent expansion. Incomplete stent expansion, that is when the stent struts do not contact the intimal surface, can occur particularly in ectatic vessels at post-stenotic dilation or aneurysm sites and in the ostial LAD, where the operator is cautious about performing a high pressure balloon inflation in the left main trunk. The IVUS image of incomplete stent expansion showing stent struts not attached to the intima, which can occur in the ostial LAD lesions or in the ectatic vessels post-stenotic dilation site. In the later case, dilation of ostial lesion with only the shoulder of balloon does not provide sufficient expansion force to implant the stent fully. Dissection at the stent margins. Stent dilation sometimes cause a plaque fracture or dissection at the edge of the stent and vessel, which requires additional stents to stabilize the newly produced dissection. So here initial result and further dilations which have caused distal plaque fracture as shown in the figure. Overexpansion of the stent may cause distal dissection. Plaque fracture may result from misplacement of balloon post dilation, especially if the balloon is clearly oversized relative to the angiographic vessel size. Plaque fracture can also occur even when the balloon is positioned within the stented segment, especially in calcific lesions or vessels. In more elastic or soft lesions, this is less likely to occur, but it can be seen at the stent margin when the stents are deployed on bent lesions. A plaque prolapse through stent struts may occur in 5% of coil type stents implantations. Although the coil stents have advantages in flexibility, the stent structure provides less complete radial support to the vessel wall. Further dilation does not improve the stent lumen cross-sectional area. An additional stent within the primary stent is necessary. Dissection at the stent margins. Stent dilation sometimes cause a plaque fracture or dissection at the edge of the stent and vessel, which requires additional stents to stabilize the newly produced dissection. So here initial result and further dilations which have caused distal plaque fracture as shown in the figure. Overexpansion of the stent may cause distal dissection. Plaque fracture may result from misplacement of balloon post dilation, especially if the balloon is clearly oversized relative to the angiographic vessel size. Plaque fracture can also occur even when the balloon is positioned within the stented segment, especially in calcific lesions or vessels. In more elastic or soft lesions, this is less likely to occur, but it can be seen at the stent margin when the stents are deployed on bent lesions. A plaque prolapse through stent struts may occur in 5% of coil type stents implantations. Although the coiled stents have advantages in flexibility, the stent structure provides less complete radial support to the vessel wall. Further dilation does not improve the stent lumen cross-sectional area. An additional stent within the primary stent is necessary.